That being said, I wanted to remind you that today we're going to focus on the topic of depression. Now, don't forget, this whole series is built around the concept of age-friendly care. So we're going to go over some of the basics of depression. You might remember there are 4 M's in age-friendly care, mentation being one. And so depression falls under that mentation category. We're going to talk about how your facility can approach depression for residents and as a part of age-friendly care. And then we're going to partner that and talk about ways that facilities, organizations can support daily caregivers in their own health and well-being needs. So we're looking forward to that. We'll present that today. And then we're going to hear from Megan Mapes, and she's out at Annaby Home in Norton, Kansas. We can't wait to hear from her. Megan, I want to thank you for sharing your case. Anytime we can learn from real life situations and real life barriers, then we all learn the most because we're learning together and sharing our resources. So thank you so much. We'll be hearing from you a little bit later. Now I'd like to introduce you to our team, and then we'll step into our slides for the day. Kim, let's start with you.
Okay, I like that you always start with me. I'm Kim BERGEN-JACKSON, and I'm the administrator at Oaknoll, and I'm also an adjunct faculty at the University of Iowa College of Nursing. So that gives me an opportunity to work with SHAWNA and her team. And I have a specialty team from Oaknoll here. So I'll toss it to who's first on my screen? Sarah.
Get the mute off. Good afternoon. I'm Sarah RUHLMANN. I'm the director of nursing at Oaknoll.
All right, let's pass it to KALEIGh next.
Hi, everyone. I'm KALEIGH GILMORE. I'm a social worker at Oaknoll.
So good to see you too. Paige?
Hi, everyone. I'm Paige. I've been at Oaknoll for 12 years, CNA and restorative aid.
Good to see you today. And STACIA?
Hey everyone, I am STACIA Green at Oaknoll for almost 11 years, and I am also a CNA and a restorative aid.
Good to have you. Okay, Kim, I'm going to mute myself and let you start with the slides, and you toss to me whenever you're ready.
Okay, will do. Thank you very much. So, as SHAWNA said, oh, there we go. The learning objectives for today are to describe one of 2 main symptoms that must be present to make the diagnosis of depression. So we're going to differentiate between depression and situational sadness and grief and loss and all those other things, and also identify at least 3 strategies that will encourage self-care in the work setting for our caregivers, our daily caregivers. I think first, though, we're going to pop up a poll question. So poll question number 1. Oh, go ahead, SHAWNA.
This one's pretty simple. True or false? Depression is a normal part of life. True or false? And don't forget to hit submit there after you've responded.
I almost gave the answer away before the poll question even popped up.
All right, let's give this 10 more seconds and show everybody. This is a bit closer than I was expecting, Kim. But we'll let everyone finish getting their responses in, and we'll show you what people are thinking. All right, Kim, so it looks like 45% of our participants and learners today are saying that's a true statement, and about 55% are saying false. What do you think about that?
I think it's interesting how close it is.
I do too.
I would say that as we talked about briefly, grief and situational sadness and loss are normal parts of aging, normal parts of life, but depression with a diagnosis is not necessarily.
There's a difference between having signs and symptoms and being diagnosed with clinical depression.
Right.
And so it's not necessarily a normal status to have clinical depression, but throughout the lifespan, from the time you were an adolescent to the time you were an older adult, probably half of the US population will probably qualify for that diagnosis at least once in their life. But it's not a normal way to live, is it, Kim?
Right. I think this time we have 2 poll questions, actually, so I think there'll be a second one.
Oh, thank you for that. Question number 2. There is nothing I can do as a daily caregiver to help with depression. True or false? There is nothing I can do as a daily caregiver to help with depression. Don't forget to hit submit. The answers are coming in really quick on this one.
Are they?
And I'm not surprised by where this is trending. Let's give this 10 more seconds and show everyone. Now, Kim, I'm thinking that we've got this one right, but the answer to that is false, and
Correct.
everyone's on the same page with that.
That's great. That's great to see that. So we'll move on to the next slide, please. So as we've said before, and we will say again, daily caregivers do indeed make a big difference in the quality of life for older persons in their care by using the age-friendly framework. So keep that in the front of your mind while we're talking about the different M's of the age-friendly framework. And remember today, depression is included under mentation. There are many, many opportunities to talk with older adults as you provide assistance with their daily cares and talking to their person about their life, their interests, their kids, and their care preferences helps you learn what matters most to them. So I'm interested to hear what our direct caregivers think about that idea of talking to the residents about their life, their interests, and their care preferences. Stacia and Paige, do you want to jump in? They're like, no, I don't want to jump in already. It's too early. I know it seems unusual to ask you so early, but you just do this as a normal part of your daily work with the residents, getting to know the residents. So that's just what I want you to talk about is how close you become with the people that you serve and how that can make an impact on their daily lives.
I guess I have actually mentioned it before, but yeah, definitely getting to know the resident, their interests, what they like, what makes them happy. You know, sometimes talking about family makes them really light up and they want to talk about it. And sometimes family is not a good topic for them. And so, you know, to kind of avoid that with them.
Great.
Yeah.
That's great. Do you have anything to add, Paige?
I'd just like to add that not only just talking with them and asking about their lives and their interests, but also if you think back to, it was either last session or the first one, I don't remember, body language. Don't just talk about the things, show that you actually care. You know, if you stand there with your arms crossed or something like that, that's not really an open and inviting stance. So they may think, oh, well, she's asking about me and my life, but she doesn't really care because her body's telling me different. So just to think about it as a whole and not just what you're saying and but also what you're doing and how you're presenting yourself, just to keep mindful of that.
I appreciate that. So when your daily caregivers are focused on quality of life for residents, that greatly increases the chance of improving their own quality of life and the quality of life of residents. So I'm behind a little bit. So today we're going to talk about depression specifically. The first step in helping a person with depression to get the help that they need and deserve is to notice a change in their behavior. And our last session, we will talk about changes, just changes in general in the residents. So it's really important that the caregivers get to know the residents so that they can notice changes and hear expressions of sadness, hopelessness, and despair. You have to stop yourself, though, from saying, oh, that's natural, or I like the thing under here, being sad is understandable. I mean, after all, goodness, you have every right to be depressed. That's not untrue, but that's not helpful. So when you're thinking about that, listening to what they have to say and then interacting with them and seeing if there's any way that you can help, or just validating the feelings that they have. SHAWNA, would you agree? Just
Absolutely. Other things to avoid saying would be, oh, I would feel depressed too, right? Sometimes we want to align and validate what someone is going through, but the reality is depression can be treated. You know, even if you're really struggling, depression can be treated. So it's important to recognize it. It's important to communicate that with the team, because that's how we work together to alleviate those signs and symptoms of depression.
Right. I would add in there too that it's our nature to minimize the negative feelings for people. You're going to be okay. It's going to be okay. Things are going to be all right. And really, sometimes people just need to be heard and their expressions of sadness can be hard to listen to, or despair or hopelessness. But it's important to have a kind listening ear, I think, when you're trying to express the negative side of emotions. Next slide, please. Depression causes a wide variety of changes in mood and behavior, including physical health problems. However, one of the two main symptoms must be present to make a diagnosis, and that is either depressed mood or loss of the ability to experience pleasure, which it has a fancy word called anhedonia, but it just means that they can't really experience that happy feeling. You can imagine how terrible that would be.
And I really want to reinforce here, Kim, that anhedonia, we should not attribute it to this person is getting older, they're less active, less mobile. This is a natural state. Remember, when we're looking for depression, we're looking at changes in behavior. So if 2 weeks ago, Mr. Smith or Mrs. Smith was, behaving in a different way, we shouldn't attribute anything to aging or even illness. If we see a shift from normal, what is normal to the person functioning, we shouldn't write it off as, oh, that's just part of the aging process, because the anhedonia is real. And even if the person doesn't express, I'm feeling down in the dumps, even if we don't see them crying, this is a true symptom of depression, and we need to keep an eye out for it.
Thank you. Depressed moods often include deep feelings of sadness and discouragement, and there are sometimes crying spells and tearfulness, but sometimes there's also a lack of emotion or lack of response. So it's important to just notice the changes. Older adults may not say they're depressed. Instead, they might say they feel down in the dumps, or they're having the blues, or they're having a bad day. The person can also be depressed without having a depressed mood. Instead, that person has a loss of that anhedonia that we talked about, the loss of the ability to express pleasure in activities they even enjoy. So if you see somebody who loves cooking, for instance, and they cook once a week with somebody on your team, and you see over time that is becoming less and less enjoyable, that might be a change that needs to be looked into. The person often withdraws from the usual activities. You see them become less talkative, less engaged, and more inactive. That withdrawal or apathy or lack of emotion and indifference represents a loss of the ability in general to experience pleasure. Next slide. Thank you. Depression can cause a variety of changes in mood and behavior, including, oh, I'm sorry. Said that. Oh, I got myself lost in here, Shauna. There we go. Signs and symptoms of depression often start over a 2-week period of time, like Shauna mentioned, and can persist over months or even years if not treated. And sometimes people can have that depression and feel like that's become their normal state of being. Loss of life and stress often trigger a greater depression reaction. Loss of a loved one. We have residents who are relocating, losing spouses, and often children in their advanced age. Changes in their health or function causes them distress. Moving to an unfamiliar and new place. And pain. Pain is underreported, we know, in nursing homes, and often interferes with doing what matters for the residents. KALEIGH, I want to make sure I give you an opportunity to jump in too, as our non-nurse, non-psychologist, social work helper.
Yeah, I think, like Shauna said, talking about these signs and symptoms, so may be indicating signs and symptoms of depression, but really important to kind of balance and not immediately label what is observed as depression before it's addressed or looked further into by the appropriate professional.
Thank you. I think too, history, very often depression can be cyclical. And so I think it's important to talk to the family about whether or not these symptoms have shown up before in this person's life.
And I'd like to know what KALEIGH's thoughts are. We talked about loss. We were transitioning maybe where we're living, or we've experienced the loss of a loved one. But for some of the residents that have maybe been with us longer term, sometimes a major shift in our care team can even trigger some of those symptoms of depression. Wouldn't you say, KALEIGH, that would be something we might want to look out for?
Yeah, definitely. I think especially as care teams, staff, direct care staff are building those really close bonds and relationships with people. Certainly a change in one's employment status or a move or any type of change that would bring that would sort of sever that relationship would cause some sadness and grief. All kinds of losses that older people experience as they continue to live longer in life. So
Thank you. So although it might be tempting, and we talked about this earlier, to cheer the person up, it's really important to avoid that. Listening and being that caring, non-judgmental and accepting person is way more helpful. And if you think about your own lives, when you're talking to a friend about how you feel, you don't necessarily want them to fix everything. You just want them to listen. The feelings need to be validated as real to them, and saying something like you shouldn't feel that way often makes them feel worse. The same could be said for oversimplifying reassurances like, oh, it's not that bad, or try to look on the bright side, cheer up. Again, it's not very helpful. Next slide, please. I see a comment in the chat, but it went away.
That's from Sandra. We'll take that at the end.
Okay.
Kim, we'll come back to those after we've gotten through this part.
Okay, great, thanks. So what I want you to think about here is scheduling, adjusting the routines to support, right, the residents' physical problems, thinking about poor sleep and low energy and poor concentration. I also want you to think about, how are they eating? Do they have no appetite? Are they eating too much? Sometimes people use food as a coping mechanism. And always, I want you to look at pain management. So do they seem painful? Do they have a diagnosis of something that could be painful? Lots of times people can't self-report pain, or this generation loves to minimize that and say, you know, they're just kind of achy, but they're not painful. So tricky to act on using the words that are meaningful to them. Next slide, please. This is where we would schedule pleasant activities, like medical appointments. There's a term called behavioral activation. And so just getting them active, I would say we saw after COVID a lot of people who were hesitant to come out of their rooms. Once we trained them to eat in their rooms and do activities in their rooms and stay in their rooms because of infection control concerns, we stopped getting out and getting engaged in things together. We've had a big struggle at Oaknoll here to get people to come out of their rooms. Sarah, I don't know if you want to chime in there with just, they like eating in their pajamas in their bed and not visiting.
Definitely think that varies. I mean, we had probably a handful of residents who were dying to get back out of their rooms and back into social situations. But yeah, it's pretty comfortable to, when you haven't been coming out, to just keep staying in your room. So anything extra special you can do to encourage them to get out, or, you know, make a date with another resident who's a friend. You know, we're gonna have lunch together with this person. You know, make it special, I think. But yeah, it's going back to the last slide too. I just wanted to mention what Kim said about pain management. And I think if you live to be 90 or above, you'll probably have some aches and pains every day, but they do definitely minimize that, and that can have a huge impact on sleep, depression,
That's a good
and
point.
all the other. So
Thank you. Next slide. So I know nobody wants me to say this, but I'm going to say it anyway. It's on the slide. Promoting physical exercise is a thing. I don't want to hear it from my practitioners, and I'm not sure people always want to hear it, but physical exercise, even if it's only activity for 20 minutes out of the day, can really make a huge difference and decrease depression and improve mental health. And it also improves your physical health. So, and it also fits well with the other M in the 4 M's, which is mobility. So urging somebody to get up and engage in whatever way they can physically to be active is borne out in the research there. And work with your team members to come up with a plan for each individual person. Like we have done chair exercises as part of the Oaknoll Exercise Society, but also STACIA and PAIGE have led chair exercise groups. They make it fun. It's not all about exercise, but it is physical movement. So you have to break the cycle, it says on the slide here, of do less, feel worse, which is so true. And everyone can work together to make that happen. So this is our summary. Oh, go ahead.
Sorry, I was just going to say there may be residents who have never engaged in physical activity, and that just might not be part of what's important to them. So really getting creative with your teams to engage in that movement. It might not be an exercise group or something that someone would consider a physical exercise, but again, just creativity to think about what might work for someone who has never been involved in actual exercising.
It's a good point, KALEIGH. Thank you. I'll need you on my care team eventually.
I would probably like to add that anybody who doesn't have a lot of movement on their own, weather providing, you can take them outside, go on a walk. You know what I mean? Getting outside and getting the fresh air is nice too.
I would also add that I see a lot of movement in people when there are animals involved or kids. When we bring kids in, or dogs particularly, or llamas yesterday, people move better than they thought they could. They reached from their wheelchairs yesterday to pet those llamas in the neck. And there was lots of great range of motion happening, but it wasn't exercise. It was visiting with the llamas. So maybe it matters how we position it. So back to our summary slide, daily care providers, as we said, have many important roles in identifying older adults who are experiencing a change, which could be depression, and adjusting approaches and routines to promote their wellness and recovery from depression. Promoting engagement in simple yet doable physical and social activities, engaging with them about their lives, what matters most to them, and working with team members in the recreation department to try to add some therapeutic recreation as well. Supporting the elder to do what matters most to them will help relieve their depression symptoms for that person, and it'll build your relationship with them. You become a trusted confidant. So I really hope that you'll listen to our What Matters podcast that you'll receive after the program to hear about how age-friendly care positively affects residents, caregivers, and professionals.
Absolutely. So Kim, what Sandra has said in the chat when we were talking about what phrases might be helpful, and she said that a phrase that was helpful for her was just to validate by saying, this is a difficult time for you, or, to acknowledge that this is difficult, and asking simply, what can I do to help? Is there something that I can do to help? Just that relational kind of connection. So it wasn't a question that came up, just sharing another idea of how to validate, reassure, and offer some support.
That's great, Sandra. Thank you for that.
So now we're going to shift. I know this says communication skills here, but that's not what we're talking about. I don't think we need to, I think that's typo there. Let's move to the next slide, because really, I think, and you're going to see this slide every time we meet, what's good for the resident is good for daily caregivers. But what we're really looking at today is burnout. So what we know, particularly during the pandemic, post-pandemic, healthcare workers across the board are more likely to experience burnout in their job situation than anyone else. Now, any job that you do that you do across time, you can develop burnout, because burnout is associated with the stress that comes with your job. And if you're not having experiences of fulfillment or even getting enough downtime, anyone can burn out from any job, but we know that healthcare workers in particular are more susceptible to burnout. And when we think about daily caregivers who probably on a daily basis support and assist individuals who might even be suffering or in pain, that increases that likelihood for burnout. Now, the signs and symptoms of burnout that are listed here on this slide are signs and symptoms. You know, anyone can have a rough day, and you might see a coworker who has described recently that they're having trouble sleeping, or you might see some irritability. And that doesn't necessarily mean burnout has set in. Just very similar to how we measure or look for, you know, the clinical signs and symptoms of depression. Burnout would be a combination of these things over time. So someone having a bad day or maybe even a bad couple of days doesn't necessarily mean that they're experiencing a full-on case of burnout, but it could be a sign that we're headed in that direction. So if you're experiencing these symptoms related to work, or you see a peer or a colleague experiencing these symptoms, it's really good to think about reaching out and doing that focus on what's good for the resident is good for the daily caregiver, and looking to see what kinds of things can be done to help address burnout. Can we go to the next slide, please? Self-care is a #1 intervention for mitigating burnout. So when administratively our organizations support and promote self-care, not just the skills we talked about last time, well, actually in our first meeting together where we talked about meeting your basic needs, self-care goes above and beyond that. It really does improve stress management. It reduces burnout because we're planning activities that help improve our well-being. And that can be physical, mental, spiritual well-being. So there are self-care activities we can do outside of work, you know, like taking a warm bath or going for a walk, meditating. But, you know, some of these things can be done at work as well. And one of the struggles of being a daily caregiver is every time you come onto a shift, there's routines that you need to follow. There are job tasks that you know you need to get done during the day, but you're working with humans who have human experiences and have human shifts. So we have to address the human first, which means we might have planned to do the first 10 things on our list today, and then something happened and we've been bumped off course. So building self-care into the day, it could look like, you know, I know Kim, you had shared with us that previously in a previous life, you were a smoker, but being a smoker gave you some time sometimes to just get outside and maybe take a couple of unhealthy breaths, but you were taking some breaths, right?
Deep breath.
We can still do that. We can encourage each other. Go for a 5-minute walk. Go sit outside and breathe for a little bit. Let's turn on some music and try to shift the mood. There are self-care things that we can do at work as well. If we could go to the next slide, please. We talked about routine in terms of how reestablishing routines in terms of how to assist our older adults in addressing signs and symptoms of depression. We can be very intentional about how we address burnout as well. These are common areas where if we had a plan in terms of recognizing what our physical symptoms are for stress and burnout, what our mental symptoms are for stress and burnout, then we can build things in to our lives intentionally to really identify where self-care is needed the most, right? So maybe you are someone who has a really good exercise routine, and if you do, good for you. You know, I'm glad that's there. But if you're feeling burnt out despite having that, then maybe we need to shift and look at, have I been neglecting my relationships because I'm so stressed out at work? How can I make a plan to really enrich my relationships outside of the work setting to get the social support that I need? Or have I been so stressed out that I'm not paying attention to my budget? And now not only am I stressed out at work, but I'm behind in paying some bills, or, you know, how do I address some of those things that are causing stress as a form of self-care to help improve my functioning everywhere else? So we like to look at these different categories and then make a plan to improve our self-care in the areas where it's needed the most. Next slide, please. All right. I think that, let me look at this. This slide is from our first course. I'm not sure why it's here. So let's please move on. Let me tell you what was missing there. And the very last slide that should have been there should have said how administrators can promote self-care at work. And really there are several things that you can do. One, you can set a good example, right, Kim?
Right.
You can set a good example of self-care. You can make sure that there's an open door policy in terms of how to reach out to supervisors or even human resources if needed. We can encourage our coworkers to take time off as they need it. And if we're starting to see some signs and symptoms of burnout, and our colleague agrees that that might be what's going on, can we look at, hey, do we need to take a little time off? Do you need to take some PTO, or do we need to adjust where your shifts are so that you have time to kind of recuperate? Again, like we mentioned in that first course, how do you make sure basic needs are being met at work? Are you hydrated? Are you getting enough nutrition? And, you know, are we encouraging healthy practices? We're going to go back and talk about that buddy system, right? Is there someone who you work with who can check in on you and make sure that you're engaging in self-care? And the last one I'll mention is if you're dealing with burnout and it's really a struggle, it's okay to think about talking to a therapist. You know, therapy does not have to be a long-term ongoing intervention. It doesn't have to be one more thing that you do in your life when you're already feeling overwhelmed. There are brief therapy interventions that can really help with burnout. And if those on-the-job interventions and approaches aren't helpful, there is nothing wrong with seeing a therapist. Some of us, you know, are pretty friendly and we don't bite, and can really provide some of that support to help get you through. All right. Now, I didn't see any questions come in, Kim, as I was talking. And I know we have a case. It's a really good case. So if it's all right with you, I might ask our team to get the slides up, and let's ask Megan to please open up her microphone. We're really looking forward to hearing from you.
Sounds great.
Megan, are you able to unmute?
Yep, I think I did.
There we go. Great.
Good.
Go ahead.
Well, I am the administrator and a nurse of a 68-bed skilled facility. We also have 18 independent apartments, and then we're in the process of purchasing a 36-bed assisted living facility. And I guess kind of our case kind of fits into maybe the depression aspect. My facility, unfortunately, made national news with COVID. We had a resident test positive, and then another one, and then tested all staff and residents, and 100% resident positivity, and probably I would say 90% of staff.
Wow.
I had news crews camped out outside. I mean, just yeah, it was rough and depressing, and we have learned a lot and grown from the experience. And I think it helped us become a stronger team. And now we don't maybe question ourselves as much if we're doing the right thing, because I think we've had enough training and re-education, and learn from your mistakes to prevent that from happening again. But it was definitely a very challenging time for staff and the residents and residents' families. I don't know, just heartbreaking to lose. I think we lost 24 residents. That's very detrimental to, you know, an already small kind of facility. So I think that depression is definitely there from just knowing what could happen and learning from it, I guess. It's hard to, I feel like COVID has made it a little bit hard to get people to work in healthcare, as I'm sure every facility on here knows. So that's heartbreaking that people don't want to be in the nursing field anymore. because of all the changes and regulations, the mask wearing, all of those things. I guess and it's hard for the residents. When I was talking to Joy, we talked about how we've gone all this time learning about here's all these regulations and you can't isolate your residents and you can't let them refuse to do things, and this is their home, and you know, these are all the things you're going to do to make it a home experience. But then COVID happens, and then we pretty much isolate them and we don't let them do whatever they want, and they can't refuse to come out to the dining room or come out to activities. And so not only did you have residents who you know, then their whole life has changed, then you also they lose their friends and their families not coming in, and it was just a very very depressing time. And to think that if we didn't get our facility back in compliance, where would the residents that I did have that were healthy and recovered, where would they go? What would we do? So I feel like that's the biggest challenge, and especially with the depression is, so if we have one person, one staff or one resident test positive, then we go into an outbreak, and that's at least 14 days with no new negative or no new positives. So how do we still make it feel like a home? And how do we keep our residents from getting depressed? Because I have residents who will tell me when they have to, then when we don't do community dining and activities, they say, I'd rather get COVID again than have to sit in my room and look at these walls for the next 14 days. And why did we get the vaccine if we have to still stay in our room? And I have a gentleman who every time we're in an outbreak, he declines so much he has to have therapy again to get his strength back. So how do we keep our residents physically and mentally healthy when we're still trying to protect them from COVID?
Wow, good questions. I hope we get to tackle all of them. I will tell you that as I'm doing a quick synopsis, if you have any other clarifying questions you'd like to ask Megan, we'll take those in the chat, or you can open up your microphone. Before I do a brief synopsis though, Megan, I want to thank you for being here and for sharing your story. What you went through, what your staff went through, what your community went through was not easy. And there's so much that we can learn from you and what you experienced. So thank you for being here and sharing your story. I remember those news stories when they happened, and we were standing up the nursing home echo at that time. And, you know, boy, our hearts went out to you all and what was going on, because really it could have happened anywhere, right? It could have happened anywhere. And the fact that you are still standing is amazing. So you have a 68-bed facility. You're looking at growing. Right now, you keep 10 rooms empty in case of COVID outbreak. And I have a clarifying question. I'm going to wait for others to come in, but it sounds like quite a bit of your staff, you know, I'm sure you've had some staff turnover, but you still have staff with you that went through this COVID outbreak with you, is what it sounds like to me. Is that correct?
Yep.
All right, let's get to some of the questions that are coming in, Megan. Paige is asking, what do your restrictions look like now compared to when COVID first started?
Well, luckily we still have we have visitors coming in. We're just testing on symptoms or new admits, and so we're not testing all the time like we were. We still are encouraging staff to get COVID vaccines and residents. But whenever we have, you know, a new positive case, then we do no community dining, no community activities, and then everybody stays pretty much in their rooms for that till we go 14 days with no new positives.
So Paige was, KALEIGH was clarifying, if you have one resident positive with COVID, everything shuts down in your facility?
And I
Yep.
followed up with a question on private rooms. Is it possible for you to use private rooms for the residents and not have a roommate?
Yeah, we do have some private rooms, yes, but then we have a lot that are in semi-private.
Mhm. I can just tell you what we're doing here, and we're using a private room isolation. So if somebody, we don't have anybody positive today, but if we did, we would only isolate the person who was positive. And then
Yes.
we
Yep.
would continue community dining though, and we would continue community activities, and we would just test people who became symptomatic. If there was a known exposure, we might test people who were asymptomatic, but we've really moved beyond that sort of strict guidance. That you're right, it happened to all of us, and it really set person-centered care back on its toes a little bit. All of those restrictions, you know, what we
Sarah's
did.
asking about your vaccination rate. What does that look like in your nursing home?
When we first started with the vaccines, I was sitting at 90%. And I think a lot because a lot of the staff that was getting vaccinated, went through it. So I think it was really good then. I'm sitting right now possibly at, I would say 75%.
So I want to go back to what Kim was talking about. It's helpful to know where you're at vaccination wise, because of what you and your organization went through with COVID. Do you feel an extra strain of like regulatory oversight? Like there is not a misstep anyone can take here? Or can you talk to us a little bit more how the policy, because many nursing homes have shifted policy to something very similar to what Oaknoll is doing, where if there's someone who's positive, we address the one positive rather than shifting really the quality of life for everybody else who's living and working in the facility. Are your adherence to policies because it's just what, you know, feels like it needs to happen after what you've been through, or is there more regulatory oversight because of what happened at the onset of the pandemic?
I think we could I mean, I think, yes, I think I'm probably a little overcautious. But I do think last I knew, and I have a group that, I guess since the public emergency has ended, I don't know how that changes for us. There is I have 2 isolation rooms and a COVID unit if I would have to use more than the 2 isolation rooms. But they still, the recommendation from the infection control group that I use still suggested no community dining and activities if you have several or 1 resident or 2 residents. So I do think I do probably maybe out of fear to have your facility be that 100%. And then to you know, like I got off of social media probably for over a year. I had people telling me that I should be in federal prison for murder. I had people sending me hate mail.
Wow.
I mean, it was just awful, especially when you live in a small community like this and everybody kind of knows everybody. But so yes, in a way you feel like you have to protect them, because if you don't, then you're going to get blamed for what happens. We did have at one time 2 wrongful death suits that ended up not going through court and closing. But so yes, there is a little bit where I feel like I'm under a microscope and not sure when that microscope might lessen. So I don't know. It's a struggle to know, because when you think of, you know, when I was talking to Joy, at the time, when we had the very first resident test, they had a roommate, and I left the roommate in there because to me they'd already been exposed. So don't take them to another room. And that was my first harm level deficiency. So after over $300,000 in fines, and then OSHA came in And I actually had the person from OSHA say, we probably never would have looked at you, but because you made national news, now we're coming in to investigate you. And the Attorney General, because you made national news, now we're going to look at you. So probably maybe a little bit of fear too, a little always feeling like you're judged, I guess, more than just our jobs anyway.
Right. Megan, just before we say anything else, I just want to thank you for still being there and for, you know, for making it through. A lot of people did not make it through the pandemic and left long-term care in general. And we can clearly see how passionate you are about it. And I just have to give you some kudos for hanging in there, and good for you.
Thank you.
And just remember that it was a virus, and the reaction in social media and the news and in the government, you know, they were horrified by the deaths that were happening, but you can't stop a virus no matter what you do. And so you did everything you could, and I give you props for that.
Thank you.
I'm very proud as well that you are still standing here. I think it speaks so much to your passion and your willingness to kind of steady the ship. You know, it's something that you said earlier. I'll tell you that in residents that I've worked with, you know, after we're a year into this pandemic, I can't tell you how many times I heard, I've been vaccinated. Why do I have to stay in my room when someone else gets COVID? I would rather get COVID again and die than have to be locked in my room for 14 more. I mean, people were saying I'd rather die than not be able to return to my normal life. So, you know, when we look at, you know, how to mitigate the health risks with the virus versus really the very deep and suffering struggle that people feel when they aren't connected and relating. No one else within this group has walked in your shoes. So you have to make decisions based on all of the information. But I will tell you, I think that if you're not already implementing age-friendly care, we have a workbook and a guidebook from IHI, from the Institutes of Health Improvement, that I think could do wonders. One, with looking at, you know, what is some of their guidance in making some of these decisions, because I really wonder, I think it's great that you have a consultation group that talks about and focuses on, you know, mitigating infection or the spread of infection. But my first question is, what do they understand about psychological well-being? Because that can be just as deadly sometimes. And if we're not mixing the two and looking at all of the things that go into health and well-being, then we're really doing a disservice. But that age-friendly care approach really helps build that sense of purpose and community, not only for the residents, but for the daily caregivers as well. And I think that, especially you asked about, you know, team building activities, becoming person focused, person first, resident first. And a question I would have there is, do you have a resident council? Do you have a voice for the residents that can provide feedback as well, in terms of, you know, what are their choices in their home? There are some times where we have to go with the letter of the law and what the CDC says. And then there are times where people should have a human voice. Do you have a resident council?
Yes, we do. And we actually have residents who go to the meeting and actually are the president and the secretary and all of that stuff. So yes, we have a pretty decent resident council here. Right now, I only sit at 40 residents. And since COVID, I haven't been over 44.
Okay. I'd like to hear from the rest of the team, particularly when it sounds like in the facilities that I'm familiar with and in my area is that I'm not aware of any other facilities that are doing that complete lockdown. Are there any other facilities online with us that would mind sharing what they're doing when they have a positive in the building or in the community?
I will say, thankfully, I have not had a positive since December. So
Good.
knock on wood, hopefully we'll change that, but yeah.
Well, then let's move and talk a little bit about team building. Can we go back, Megan, and ask of your staff that's on with you right now, how many are new staff post the outbreak in your facility, and how many are like you, that they've weathered the storm and they're still here, and it's because of their attachment and passion for the work that they do?
I would say 75% of my staff are still here. I have nurses who have been here and CNAs who have been here for 40+ years.
Wow.
So, and I have a strong leadership team. My director of nursing weathered the storm, and the infection control is new. And so I would say 75% of my staff is still there, and then some new. But yeah, they are very committed, and I think that is why, is because the love of the residents and the love of the family we've made here.
Can I ask, Megan, do you think your staff would be responsive to, so periodically throughout the year, we have sort of a grief and loss workshop. Sometimes it's driven by our hospice providers, sometimes it's driven by our social workers. But I think if we lost 24 residents, and we have 58 in our health center, so I sort of can relate to your size, I would have a little bit of PTSD for sure. And I wonder if they need some sort of a cleansing ritual or something to honor the residents that they lost, to let go of the guilt that they feel because they feel like it's their fault, because I know how they feel. You know, is there something that you can do for the staff to do a reboot? Like we're going to start over, and we're going to start patient-centered, and we're going to love the residents and forget about all that COVID in the middle.
Yeah. When we had the first nursing home week after COVID, we have outside, one of our activities for nursing home week was to plant a tree for all those residents. So we have a memorial tree out in the front yard for those residents that we lost. But yeah, I mean, I think there's, something like you said, some kind of grief or loss or some kind of workshop, that is a good idea.
Now, something that I'll mention, and I know that it's just about the end of our time together, but you know, at this point in terms of timeline, an approach like critical incident stress debriefing, we're too far out for that to really apply here, but it's very similar to what Kim is saying. So I don't know if you had anyone that came in at the time where you were trying to recover from all of this, but critical incident stress management or debriefing really can be so crucial after an organization experiences something this stressful. It helps mitigate the PTSD, right? And all of those other things that can show up. You know, and I'm not even just thinking about the psychological healing, but when the majority of your staff experience COVID, especially that early on, returning to work and having the energy to work must have been an uphill battle, just physically taking that on. And then you couple on the psychological stress and grief and loss. I think you're all warriors. I really do. In the future, I would think about community resources that could do critical incident stress management after an experience like that. I don't know if you had that offered to you, Megan.
Yeah, not that I remember, but you know, I was just honestly, to be honest, I was just trying. Yes. I mean, so the KDHG pretty much just said who got to come to work and who didn't. And so at the time, I didn't have anybody in the leadership team that could stay here. Everybody else had to go home, be quarantined. And so I had surveyors in every day. So I just, survival mode, just trying to keep the facility open. But if we ever experience anything like that, that would definitely be something to reach out to and get those resources.
So, and I agree with Kim. I think that something that brings you together, something that might be outside of work. I know someone always has to be there at work, but to have an event where you celebrate, you know, where you've been, where you've come, and you know, do some team building that way. I really think that if you were to go through that age-friendly workbook and guidebook, that would give you some ideas in terms of just building that whole sense of community. So I'm going to encourage that. I like to thank our partnership with the University of Iowa's geriatric education, geriatric workforce enhancement program funded through HRSA. And we want to let you know that because you attended today, your organization and all of its daily caregivers can now open up this online training. Remember, it's a 3-phase training where your daily caregivers can learn about depression as a part of mentation. There's a fun podcast in there that talks about how those things show up in real life and how we can respond. And then there's a segment on how to address burnout as well. So please keep an eye out for that.